All right. Next up, we have a talk that's going to be given by Dr. Lord and Victoria Banks. Dr. Lord is a physician scientist with a focus in inflammatory bowel disease at Virginia Mason and at the Benaroya Research Institute. And in addition to caring for patients with IBD, he has an active laboratory that studies why people get inflammatory bowel disease and how new therapies may work. He obtained his MD and PhD in immunology at the University of Washington. He also did his residency and fellowship in GI there. He serves on the Crohn's and Colitis Foundation Northwest Board of Trustees and is a member of the Chapter Medical Advisory Committee and the Foundation's National Government and Industry Affairs Committee. Victoria Banks is a law clerk to Snohomish County Superior Court Judge Janice Ellis. She is also an IBD patient, and their presentation is entitled Advocacy and Legislation. Thank you so much.
So hopefully everyone can see the slideshow now. So I'm going to be talking about advocacy and legislation efforts both at the state and the federal level with regard to inflammatory bowel disease. And this really is paying in particular attention to what's happening with the legal environment surrounding the medications we use. I am a medicine doctor, and so I'm predominantly going to be talking about how this affects our major tool in the clinic for treating IBD, namely the medications that are rapidly expanding our repertoire of treatments for inflammatory bowel disease. So ideally, a treatment regimen for any sort of a condition evolves from a doctor-patient relationship in which both mutually agree upon a plan by which to treat that. Now, each of them has veto power over this plan. The doctor can refuse to prescribe or decline to order something, an impulse which is held in check because we don't want to make medical errors or disappoint our patients. The patient in turn can neglect to take therapy, cancel appointments, or just decline consent for whatever the doctor has to offer. And that is in turn held in check by concern that you might suffer pain or suffering as a consequence of not moving forward on a plan, or again, disappoint the doctor. However, there's a third member in the room that is kind of unseen at the time that we're making these plans to treat a patient, and that is the payer. Because of the way that healthcare is delivered in the United States, the mechanism for paying for this plan is typically through an insurance plan or a federal system such as Medicare or Medicaid. And if coverage for that plan is denied, it effectively is a third form of veto power that can influence our ability to offer a particular treatment plan. And so there is a term that has come to the fore in the past couple of decades called utilization management or utilization review. It's a strange, very non-specific term, but what it's referring to is, quote, a set of techniques used by or on behalf of purchasers of healthcare benefits, i.e. health insurance, to manage healthcare costs by influencing patient care decision-making through case-by-case assessments of the appropriateness of care prior to its provision. So basically, they decide whether or not something is a particular treatment they're willing to pay for before that treatment is offered. And what this looks like is, for example, if your doctor orders a lab test, the hospital or clinic has to actually contact your payor, insurance plan, prior to getting authorization. So this initiates a check to make sure that the health plan gives a pre-authorization or PA, and we have to talk to the health plan office, pick the plan specific form, fax that form in with attached medical documents showing why we want to do this. And this is reviewed by an insurance agent, and they clear the approval, hopefully in a day, but sometimes it can take more than a week to get pre-authorization. And if that pre-authorization is denied, then you can end up with a rejection and appeal cycle that can last days to months. So here's an example. Here are a few examples of utilization management that can actually limit our ability to provide healthcare. For example, a clinic will not perform a test until they first get permission from insurance to run it. And in a place like Seattle, where a lot of our patients are coming from out of state or from a long way across the state, This often necessitates multiple trips where you show up one day to the clinic to come up with a plan, and your doctor says we need to do a particular test like a CAT scan. You have to wait a few days for the authorization. So you go home to Alaska and then come back again to get that CT scan. So it can actually result in fairly disrupted care. A pharmacy might not refill your existing prescriptions at the start of each calendar year because they need permission that you are indeed continuing your current medication before they will authorize payment for it. So this can actually disrupt drug treatments. An insurance company will stop paying for an ongoing therapy until you get proof that it works. They may have authorized the use of a medication and then 3 months later say, okay, now prove to us that this actually worked before we will continue to pay for it. And then coverage for an ongoing therapy may be shut off because something changes. The insurance plan can change for a patient. We often change jobs. Our employers often change the insurance plans that they contract with. Or even within a particular plan, if nothing has actually happened, your insurance plan may change the medications with which it contracts. And finally, there's something called step therapy, which is really at the heart of what I'm going to be talking about today. And this is for people who are starting a medication from scratch. So step therapy is an increasingly common health insurance policy where you have to fail a particular medication before you can actually use the medication that is recommended by your physician. So you need to prove to your payer, insurance or other plan, that you either don't tolerate it because of toxicity, side effects, maybe an allergy, or that it just doesn't work, that it's not helping after enough time has been given to see if it would help. So for example, if you, let's say you tried a drug like infliximab, Remicade, it didn't work, and your doctor recommends another drug like vedolizumab or Entyvio, it's a pretty common scenario for your insurance to say, we're not going to pay for Entyvio until you first demonstrate that Humira, a drug similar to Remicade, does not work either. This is a fairly common phenomenon that happens a lot in my practice. So step therapy is on the rise. Between 2005 and 2013, the percent of health insurance plans that had step therapy policies more than doubled. And if you look at the number of products that in a couple of common payer systems that were excluded as first-line therapies, you can see that between 2012 and 2017, in just a 5-year period, there was a marked expansion in the restriction of available medications. So why are they doing this? According to the Director of Communications for American Health Insurance Plans, it is, quote, to protect patients, ensuring that the treatment is safe, medically necessary, and appropriate. And so according to this statement, employment of this practice is primarily to create a redundant line of quality control for medical health care beyond what the existing healthcare system provides. I may question its necessity, but what it clearly does is discourage the use of expensive therapies. And so one can certainly argue that there is a financial reason underlying this more than a quality control issue, as it does allow insurance companies to negotiate with pharmaceutical companies. Presumably there are undisclosed discounts effective on these medications that are being exchanged for the captive market of subscribers to a particular healthcare plan. And so this theoretically lowers the cost of healthcare, which is beneficial to society because it results in cheaper premiums for subscribers, but at the same time, one can cynically point out that it can also result in higher profits for the shareholders in healthcare payers. Now, there are some potential problems with step therapy. First of all, there is a lack of transparency. It's unclear what discounts are driving these policies. We don't know the nature of the discount agreement or the magnitude of the discount. It's unclear what drugs are or are not covered in many policies. It's actually quite difficult to figure out at the time that you're subscribing for a healthcare plan what the medications are that are going to be covered, both to the subscribers selecting the insurance plan and also to prescribers making treatment decisions. And finally, there's a lack of consistency, even from plan to plan or month to month within a given plan. There's not a consistent set of preferred drugs across the board. And the process by which we request authorization to appeal denials is also very inconsistent. This creates a lot of frustration and challenges for the providers of healthcare. And part of this is because the process is used to obtain authorization and to appeal it are extremely complex and confusing. This is a real slide of one particular institution's mechanism for obtaining prior authorizations, and I can't even begin to follow what this actually is trying to explain. So there are potential problems with step therapy. It delays effective therapy, and that can increase suffering, disability. In inflammatory bowel disease, it often results in increased prednisone use, which results in its own toxicity. And in this day and age, certainly a concern about infection risk that Dr. Kiorian mentioned earlier. It can increase hospitalizations and increase surgeries. And paradoxically, despite its efforts to decrease costs, all of these are associated with raising the cost of healthcare for patients with inflammatory bowel disease. And so in some models, it may actually be cost neutral to have step therapy protocols in place. It also generates avoidable risks of medication side effects and toxicity. And one unique problem for the biologic drugs is the so-called anti-drug antibodies that can develop with intermittent exposure to a medication. So if, for example, you have to try and fail a drug before you can actually get the drug that your prescriber wants, then that may eliminate any potential future use of the insurance preferred drug if years from now you decide, well, actually, we do need to go back to that, or there's some new context in which you may want to use, for example, Humira. It may not actually be possible because years ago you trained your immune system to reject it because of a transient exposure. So how big of an impact has step therapy had? Now, this is even 4 years ago, and I think the problem's only grown since then. But back in 2016, the Crohn's and Colitis Foundation actually performed a survey of 2,600 IBD patients. Of these, 40% had been subjected to step therapy, and of those 40%, nearly all believed that it was a barrier to timely and appropriate care. It tended to delay therapy by more than 3 months in more than half of these patients, and by more than 7 months in a not inconsiderable minority of these patients. In many cases, their doctors were unable to appeal these step therapy decisions, and it was not at all uncommon for patients to have to fail not just one, but more than one drug before they could eventually get to the medication that their doctor recommended. So getting back to this doctor-patient relationship in which the payer is now having an inordinate veto power, the way around this is what's called an appeal. So the doctor does have the authority to request that the rules be waived in a particular circumstance. But in reality, the appeals process is actually quite challenging. Here's just an example of the type of thing that can happen. So we prescribe a particular medication, it's submitted for pre-authorization, and if it's not actually already one of the approved therapies, it's automatically denied. So we submit a brief written appeal of the denial, and there's typically an automatic process that will electronically review this and deny it very, very quickly, within a few days. So then we have to submit a revised appeal of denial, which cites the rationale and some scientific data supporting the prescription decision. The second appeal is reviewed by a pharmacist and denied. And then we end up writing a third appeal of denial, in which we can request a peer-to-peer discussion with a so-called like physician, although in truth, what we typically get is somebody who is not as close to the field in which we're treating as we are. We'll discuss the basis for appeal with the prescriber, usually recommend step therapy policy be waived and coverage approved. So obviously, this is a very inefficient process. There are many steps, each of which adds days to weeks of delay. Frustratingly, we physicians are remarkable Luddites, and there's still an archaic reliance on some ancient technology such as fax machines and telephones that frequently results in lost, misdirected, or misinterpreted communications. It's laborious. There's a lot of redundant circular communication between the clinic and insurers, which require a lot of extra people to be hired to review the literature, write letters, make phone calls, wait on hold. It's expensive as a consequence. So, and these costs are not directly billable to the insurance. So it's not like it happens for free. Those costs just get shifted onto other aspects of healthcare. And so the things that we can bill for just cost more in order to pay for the things we can't bill for. It's also inaccurate. The policies are often based on misinterpreted or out-of-date research. The decisions are often based on little or no specific information about the patient. And appeal reviewers are often less qualified or experienced or trained than the prescribers are to determine the validity of the appeal. There are letter templates for appeals to facilitate some of this, and so there's a website here you can screenshot to help your healthcare providers write these letters of appeal when such things happen. This is just one example shown here, but there are many different appeal letters that are available on the Crohn's and Colitis website. But in truth, the system is still facing a lot of challenges. Fortunately, there is hope on the horizon as we have been working to generate legislative solutions to this problem. And one of those I want to talk about today is something called House Bill 1879 that was passed into law almost exactly a year ago. And let me walk you through this because it was a great victory for our local Crohn's and Colitis chapter. In February 20th of 2019, the Crohn's and Colitis Foundation, along with some other patient advocacy groups, went down to Olympia to lobby on behalf of our patients in support of this particular bill, House Bill 1879. And we managed to talk to some of the people who are on the Health and Wellness Committee in the House. Nicole McCree happens to be my own District 43 representative, and so she voiced a strong support for it. Literally 2 days after this event, carried the bill out of the committee and brought it to the floor for a vote, where it actually passed unanimously on March 8th of 2019, and then was carried out of committee in the Senate the next month to be passed unanimously on April 12th. And then finally, on May 1st, 2019, Governor Inslee signed into law House Bill 1879. Unfortunately, in order to get this unanimous passage, we did agree to, or I should say, our legislators did agree to a delay on the institution of this law until January of 2021. So it will not actually take effect until, what are we, about 9 months from now. But at that point, several changes will happen. And at this point, I'd like to turn the mic over to my colleague, Victoria Banks, who I should introduce is a friend. She's also married to a member of my lab who works on inflammatory bowel disease immunology research. And she's also a patient of mine, and said I had permission to out her as an ulcerative colitis patient who has personally suffered the effects of step therapy. So seeing as I am not a legal expert, I am going to hand over to her at this point to explain what House Bill 1879 actually is.
Can you hear me?
Yes.
Okay, great. So the good news is that House Bill 1879 is encoded as a law here in Washington, and it serves as a check on what Dr. Lord has already explained that step therapy does to patients. And there's sort of three central tenets to the law that make it pretty powerful. The first is that it's got sort of rationality ingrained in it. It requires insurance policies to make decisions on patients' medications based on clinical evidence and the best available clinical evidence. The second central tenet is that it requires these processes to be transparent. So how to make an appeal, how to challenge an insurance policy's decision, that has to be readily available on an insurance policy's website to both a doctor and their patient. And finally, this is, I think, pretty key for both patients and for doctors. It's got to be timely. There's the insurance policy has to turn around within 3 business days, or the request is automatically approved, which is really pretty powerful if you think about it. I think what is really important to note is that this is not discarding or getting rid of the step therapy process. It is serving as a check on that process. So it also doesn't cover, if you could go to the next slide, it does, oh, yes. Okay, so more than 50% of state legislatures have passed similar laws, which means that, you know, patients in those states are covered and have the same kind of check on insurance companies and the step therapy process. And then a good number of states are attempting to pass these kind of laws through their legislatures. So that means it's gaining traction across the country. However, if we go to the next slide, this does not mean that everyone who is being treated in Washington state is covered by House Bill 1879. So if we have a patient who's coming in to see their specialist from out of state, from Alaska or Idaho, they're not going to be covered if they're seeing their specialist here well, I'm here in Seattle, so here in Seattle. Other examples of people who wouldn't be covered by this state law are people who are insured via Medicare or Medicaid or similar federal programs, or people under so-called self-insured or self-funded insurance via large employers, and also privately fully insured insurance programs. So we'll see on the next slide that that's just it's a large percentage of people covered by insurance. They're at major companies that are not subject to these state laws. And then finally, we see some of this momentum building at the federal level. So a very sort of mirrored law, it has been introduced in the House of Representatives in Washington, D.C. And it has sort of the same three central tenets we see as House Bill 1879, which is really exciting to see on a federal level. And then we also see exciting legislation like the Medical Nutrition Equity Act that's been introduced in the House, which would expand healthcare coverage to things we haven't seen in the past, like medical foods and vitamins and amino acids that we see IBD patients needing access to. So with that, I'll hand it back over to Dr. Lord and turn off my mic.
And so thank you very much, Victoria. I want to make another plug here that in addition to our local level efforts through the Crohn's and Colitis Foundation to support patient advocacy and lobby for legislative change to help patients, we also have a national effort, what's called the Crohn's and Colitis Government and Industry Affairs Committee, which is a group of physicians from across the country. You can see a variety of different institutions represented here, that is working with Crohn's and colitis staff to lobby in Washington, D.C. in support of these federal laws that will hopefully close this fairly large loophole for people who are on self-insured plans or federal plans that are not currently covered by state law. And there is something called the Congressional Crohn's and Colitis Caucus. There are actually a number of legislators at the federal level, predominantly members of the U.S. House of Representatives, that have signed on to become flag bearers for this effort to support the rights of patients with Crohn's and colitis. And this is a bipartisan group led by both Democrats and Republicans, such as those pictured here. And this is meant not only to protect patient access to care, but also to raise awareness about IBD and support medical research, much of which is funded at the federal level. And this effort so far has seen fruits. So lobbying for patient rights is nothing new. The Americans with Disabilities Act went into effect in 1990, but it's actually a fairly recent amendment just 12 years ago that included inflammatory bowel disease in this. So now employers are required to make reasonable accommodations, such as time for restroom breaks, keeping you close to a restroom when you work, time off or unpaid leave for doctor's appointments, flare-ups or hospitalizations, flexible work schedules, telecommuting, reassignments, all based upon the needs of this, which were not actually covered under the ADA prior to 2008. So patient advocacy and lobbying has actually been, has made real changes in the lives of IBD patients within the past couple of decades. Furthermore, at the state level, there's something called the Restroom Access Act, or ALI's law, named after Allie Bain, who, when she was 14 years old, started lobbying for change to support restroom access. And you can see that a number of states have already passed laws. She's originally from Illinois, but a number of states, including our own, have subsequently taken on bills exactly like this that require retail business with toilet facilities for employees to allow their customers with specific medical conditions to access them if the need arises. And so that includes patients with inflammatory bowel disease. This is considered an extension of the Americans with Disabilities Act. And you can actually get a card from the Crohn's and Colitis Foundation to access the bathroom. You can see from the name, this is actually an older card. The new ones are entirely white. But contact your Crohn's and Colitis Foundation, and you can actually get a card to carry around in your wallet to reap the fruits of these patient advocacy efforts, and take advantage of the fact that you have the right to use a restroom, a non-public restroom in a public situation. Also, don't forget that one of the major fruits of our labor is federal research funding. The Crohn's and Colitis Foundation does do their own foundation-based funding of research programs, but in addition, there are a number of federal programs such as the CDC's IBD epidemiology program, which is studying factors to improve care and targeted interventions. The NIH and the NIDDK is actually the largest source of public biomedical research funding in gastroenterology. And there's also a similar program in the Department of Defense that we have lobbied to keep IBD included in their funded programs since 2008 because there is an increasing prevalence of IBD among veterans. So part of the goal of today's talk was to show you what we have been doing and what the laws are doing to change to make it easier for patients with inflammatory bowel disease to get the care they need. But part of the goal of this talk is also to encourage people out there that you can make a difference, to show that advocating for your own rights as inflammatory bowel disease patients is a worthwhile effort. And I'm really kind of floored by how effective it was to lobby at the state level to make real changes that are going to go into effect this January. So I encourage people to check out some of these resources. The Get Involved, Be an Advocate URL at the top is really kind of the master website. But there's also an email, advocacy@crohnscolitisfoundation.org. There's also a listserv email, crohnscolitisfoundation.org advocacy. And if you don't want to use your computer, you can just text IBD advocacy at 50457. That will get you to sign up and receive text alerts from the Foundation's advocacy team about important issues that could affect you. And even if you do none of the above, simply writing your legislators, especially at the state level, has a remarkable effect when a significant number of people do it. And so I encourage everybody to get involved. The political system is answerable to its constituency, something that I was really pleasantly surprised to see works when you really are boots on the ground down in Olympia. So, let's see, is Lisa there?
Hi. Thank you so much. What a great talk. We do have some questions from the audience here. Okay. So one of them is about is a question about diet and getting coverage for appointments for dietary therapies, like with the dietitian, or for nutritional supplements or therapies, which often aren't covered by insurance, and whether there's any advocacy going on to try to encourage insurance companies to cover these things.
Well, at the federal level, there is that bill that I mentioned. One of the bills that is currently, I believe, introduced by the House. It's still just at the introduction stage, but there is a federal law that is being considered to mandate for nutritional requirements in patients with digestive disease. I'm not aware of anything at the Washington state level that addresses that, but a federal law would be more all-encompassing regardless. The pre-authorization process for nutritional supplements, just like with medications, varies dramatically from program to program. I think actually currently some of the federal programs like Medicare are actually more permissive than most private insurers. But it is something that currently we're handling on a case-by-case basis, and it is the same appeals process that applies to medications applies to nutritional therapies.
Excellent. Short of getting involved in advocacy, how can patients find resources that will help them individually and their providers to get the types of medications that they need?
I think the easiest answer to that question is just to refer you to the Crohn's and Colitis website. I mean, I hope people took some screenshots. I don't know if these slide sets will be made available, but there is a URL on there that I breezed past that mentions one of the websites has a bunch of letter templates, and that's probably one of the most concrete things you can do is use those letter templates to show the to provide that to your doctors to fill in the blanks, and that just makes it a whole lot easier for them to advocate on your behalf.
Yes, we will definitely make the slides available as well as a recording. And I would also encourage you to use our IBD Help Center that you can locate from our webpage as well. So they can sometimes help advocate with you between yourself and the insurance company. So that's definitely a resource the foundation has.
Okay. All right. Thank you guys so much. That was wonderful talk.